Buenos dias, good morning. Can you guys hear me in the back? Okay, I got a thumbs up there. I'm gonna try to speak slowly so the translators don't have a hard time. I've been told I speak very fast, so I have to be careful. So I am an adult hematologist oncologist in Birmingham, Alabama, the other Birmingham in the US. And I see all types of histiocytic disorders. So we thought about using this opportunity to provide some education about what is histiocytosis in general. And I have two goals today. One is, of course, to provide an overview of the clinical features of histiocytosis, the three most common ones. The second goal is maybe, help us think again about what we think we know about histiocytosis in general, and then ECD specifically. And what can we learn from these histiocytosis to improve our understanding or how the nomenclature came about. Here are my conflicts of interest, not relevant to today's talk. Since we do everything for our patients, let's start with a case from my clinic. So it's a 55-year-old gentleman. In the 90s, he started having left leg weakness and some tingling sensation. Fast forward 2008, these symptoms were slowly brewing. Started having right arm, hand weakness, and started developing these brain lesions. We use the word lesion for any spot, but these are the spots in the areas that control balance, coordination, affecting ability to walk and talk. We call it posterior fossa because it's on the back side, if these are the eyes. And fast forward 2017, he started having difficulty talking and walking. Was diagnosed with multiple sclerosis back in early 2000s, based on how it looked on the scan. Got multiple treatments. No improvement. We have heard this story before, right? And then had a brain biopsy, was called inflammation with some lymphohistiocytic infiltrate. We'll come back to the case. So histiocytic neoplasms, I use the word neoplasm carefully because neoplasm means tumor. And here I use it to clarify that a lot of these, including ECD, have been recognized as a cancer. So these are very rare. I think these are underreported, but overall the incidence is about 3 to 5 cases per million per year. It's really a growth of abnormal cells. So I see a lot of other type of blood cancers like lymphomas, where you have abnormal blood cells forming tumors. Same in histiocytosis, you have abnormal blood cells called histiocytes that can affect any organ. They start to grow into organs of the body. I like to think them into two categories. One is these chronic or slow-growing ones, which includes Erdheim-Chester disease. But actually, there is this other big family called a xanthogranuloma family of histiocytosis. And then Rosai-Dorfman disease, and actually a very common one, and the first one to be recognized as a cancer among these was Langerhans Cell Histiocytosis, which is much more common in children than in adults. The other ones are aggressive or fast-growing ones, and we really don't have good treatments for those, and we are not going to be talking about them. But that is really histiocytic sarcoma. We use the word sarcoma for them still. I don't know why. But they're still staying, but that does not, the name sarcoma does not imply a type of blood disorder, but most of the sarcomas. ECD, you're gonna see this a lot. Everybody's gonna talk about it, so I'm not gonna take a lot of time talking about this. The most important thing to remember is what we knew about ECD, what we thought ECD was, how it was described, was the involvement of these bones of the knees. Many of you may have know somebody with this. Many of you may have been diagnosed because of this. So you see that number 95%. It used to be thought of 100% because it was a requirement to be diagnosed as ECD. And that's changing, and I'm going to talk about it. Other classic features are kidney, hairy kidney, wispy infiltration around the kidney. You can have diabetes insipidus, And this coating, aorta, you have that blood vessel around the heart, it can be coated. And several other organ manifestations, including the heart involvement. Langerhans cell histiocytosis is different than ECD because while ECD involves the long bones of the arms or legs most commonly, LCH involves the bones of the center of the body, so the skull, jaw, hip, vertebra, and so forth. And a lot of times it's the skull involvement in the form of these clean, punched out, almost like scooped out lesions in the skull. Rarely involves the brain directly, but can involve the coating of the brain. Skin involvement is quite common. Other unique aspect is lung involvement, which is very different than ECD and primarily seen in smokers. Rosai-Dorfman disease was the last one to the party to be recognized as a cancer. Not until 2022 was it recognized as a cancer. And it used to be thought of as an autoimmune disease or a benign condition. Even still now, patients are told it's a benign disease. You don't need to worry about it. But the most common manifestation actually is skin nodules actually. And I'll talk about how it used to be thought of as the classic Rosai-Dorfman disease, which involved the neck. Brain involvement is again rare. Bone involvement can occur, but not very, very common. But most commonly we see skin and lymph node involvement. You're going to hear about mutations a lot today. When I say mutations, it does not mean the DNA you got from your parents or the DNA you're going to pass to your children. I want to make that clear. The mutations I'm talking about is the mutations that happen in the DNA of the cancer cell or the cell that makes it cancerous and makes it want to grow. Normally, you have this pathway. We call it the MAPK pathway that carries the signal from the outside of the cell to the inside of the cell through a series of genes or proteins. What happens is, they get mutated. Different person has different types of mutation in their cells, and they ask the cell to grow rapidly, cause inflammation. Over the years, we have found these mutations, starting with the BRAF, or the BRAF V600E. When I say BRAF, I mean BRAF V600E in this context. And then other mutations, starting with LCH actually, and then going to ECD, diagnosed ECD in 2012, but then a slew of other mutations have been discovered. And you can see they're not just unique to ECD, there are similar mutations in other histiocytosis, suggesting a biologic overlap between these entities. Not just there is a biologic overlap, there is also clinical overlap. And we and others have reported over and over again that these diseases can occur together with each other in certain situations. For example, ECD can occur with Rosai-Dorfman disease. When we first reported it, we found it occurring most commonly in older men involving the testicular tissue. People have reported ECD with LCH, which is most commonly BRAF V600E mutated, and LCH happens first in those cases for the most part. And then LCH and RDD can occur together as well. We have actually reported a case which involves all three histiocytoses in one person, which tells us, well, there's a lot more fluidity. They are not these clean baskets that we can just put these into. So how do we diagnose histiocytosis? Most histiocytic neoplasms, I rely heavily on my pathology colleague. We need a biopsy, and we look at it under the microscope to make a decision, like most cancers. No tissue, no issue. We need to have tissue biopsy. Now, this is where it gets tricky. Erdheim-Chester disease, you see, this is from the ECDGA website. It has the word requirement in it. Whenever you make a requirement, it makes it difficult to diagnose. You have requirement to have this happen. You have to have many things that need to fit together, which makes it harder for people to pick up the diagnosis, and hence the delay in diagnosis. And I would argue that heavily weighted on radiologic imaging findings, very less on clinical symptoms because they can be non-specific other than the diabetes insipidus symptoms, and maybe some on pathologic features, how it looks under the microscope. But it's not mandatory. You can make a diagnosis of ECD without classic biopsy findings. Now, when you look at the ECD Global Alliance's mission, it really hinges the number one thing, and what we are doing today is raising awareness about the disease. And that feeds into the support of individuals, because you are going to be recognizing more patients and families affected by this disease, and supporting research. But the goal of raising awareness is to get early diagnosis of ECD. But how can we get early diagnosis of ECD if it is so hard to diagnose? We turn to other histiocytosis and look at the history of them. And I always believe that you can learn a lot from the history to look into the future a little bit. So when we go back to the history of Langerhans Cell Histiocytosis, it was first a case of LCH, which was not called LCH back then, was first reported in 1893 in a 3-year-old boy with diabetes insipidus and liver and spleen enlargement. Over the years, other cases were reported with different manifestations. In the bone, it was called eosinophilic granuloma. And then many years later, people were like, wait a minute, all these names, they look the same under the microscope. So they said, let's call it histiocytosis X. And then in 1985, said, no, we know what the cell is. It's a Langerhans cell. It's a type of dendritic cell. So that the name was given Langerhans Cell Histiocytosis. So they didn't say, well, you need to come up with diabetes insipidus, otherwise you cannot have LCH. So what happens because of that is powerful, right? So if I have a patient with a skin biopsy showing what any of these showed, they are usually referred to our clinic, to specialists, and they get a scan, they get all the staging. A lot of them actually don't have organ involvement, but they get all the appropriate staging done. Rosai-Dorfman disease was first reported by Dr. Destombes called as edenitis with lipid access, and then by Drs. Rosai and Dorfman, and as sinus histiocytosis with massive lymphadenopathy. They were reported in young children with massive lymph nodes in the neck. All right? Later on, it was renamed as Rosai-Dorfman disease because they looked the same under the microscope. You see a theme here? Now, what happens now? Fast forward today. Most common manifestation of Rosai-Dorfman is not this, not these massive lymph nodes. It's actually the skin nodules. It's skin involvement extranodal disease. So what happens? A lot of times I get referred these patients because of this unified understanding, and they get a staging. They come to a specialist. They may have stage 1 Rosai-Dorfman. Just giving an example, there's no staging system. But they may have one spot, but they get all the staging, they go to a referral. Erdheim-Chester disease is a little bit different. It was first reported as Uber lipoid granulomatose by Dr. William Chester when he was visiting the famous Dr. Erdheim in Vienna. Reported cases of adults with this long bone involvement of the legs with fatty cells. And this is how it looks under in a bone scan or a PET scan nowadays, right? You have both the knees involvement. And later on, Ronald Jaffe named it as Erdheim-Chester disease. Just one person named the whole disease, Erdheim-Chester disease, based on the 2 people who described it. Fast forward to today, when you look back at these cases with these classic full-blown knee involvement, on average, we found that they have 5 to 6 organs involved. And actually, most of them, or a lot of them, I would say even more than 70% have the BRAF, BRAF V600E mutation. When you do a biopsy on this, though, the biopsy will never say Erdheim-Chester. The biopsy will say xanthogranuloma, which means fatty, foamy cells, lipid fat-laden cells. It's not specific to ECD. This is the tricky part, which can be seen in other lesions too. So I'm giving you an example here. But this lesion, you look at this lesion, this looks the same under the microscope as ECD. But these patients are not getting referred to specialty clinic. They are not getting scans. So we looked at our own records for last 4 years. There were 20 patients with this diagnosis, xanthogranuloma, in the path biopsy. Only 3 were referred. 3 had more staging done. Rest are lost to follow-up. So this is a tricky piece. And part of the issue is that there are no classic pathologic features beyond this inflammation, which is not very specific for ECD. So can we achieve early ECD diagnosis really? We keep talking about getting ECD diagnosis early. And we start the clock from the symptom onset. Maybe is that the right time to start the clock? But I really ask, what does early ECD look like? Have we even defined what is stage 1 ECD, or how does it start? Because many lesions can look like ECD. You can have the skin nodules, this eye infiltration, this pituitary involvement. We had this recent case of spine involvement in a young guy, brain involvement of different types. That can look exactly the same as ECD, causing a lot of debility, causing a lot of problems, having the mutations that are reported in ECD. But we are not calling them ECD still. Thankfully, in the last few years, decade or so, we have recognized, we have allowed sort of those requirements of the bone involvement to expand, to involve this hairy kidney, right atrial mass, and coated aorta-like findings. But still, isolated involvement of those are not as well recognized because they are being seen in the rheumatology clinics and they may be missed until the bone involvement occurs. So I can't help but wonder what we call ECD is a tip of iceberg phenomena where they don't get called in the community as ECD until they develop some of these classic pictures, classic features that are in the textbooks. And there is a lot of other features that are sitting under, submerged. If we recognize them, maybe we will catch this early. Because if we keep waiting till this, it may be already late to diagnose the disease. So we don't want that damage to occur. So I just wanted us to think about it. How can we achieve ECD diagnosis early? Maybe there is a bigger bucket of diseases that look like xanthogranuloma, and some of them fit ECD and are BRAF mutated. When we looked at these cases who did not have this classic bone involvement, we actually found that they had less degree of organ involvement and less frequent BRAF mutations. And our colleagues from France and Italy are doing a very large study now, combining all the patients from all the centers. So hopefully we'll be able to get some answers to this question and help more patients get to the diagnosis. So coming back to the case, this person had worsening weakness. He saw a neurologist who knew about ECD, finally. And the neurologist said, you know what, the PET scan was normal, let me do a skin exam. And the neurologist found a xanthogranuloma on the skin. And actually the neurologist went ahead and called it ECD. What that enabled is that the patient got cotelic and started improving. So many years later, a diagnosis was made because of the xanthogranuloma of the skin. Some could argue this is not ECD, but at the end, does it matter? You're getting that big disease group diagnosed, and then you're getting them to the treatment. It takes a village to take care of such patients, so we have a whole program with different subspecialties at UAB. And we have expanded the histiocytosis working group to involve many centers, 6 centers. It's called the Histio Care Network, and we discuss cases together once a month. We have a large study ongoing that my star student, Brenda, is here. If anybody wants to know about it, you have to fill a survey. We're trying to understand how the disease affects you. And right now it's in English, but we are trying to translate in Spanish and other languages soon. So takeaway suggestions. There are many types of histiocytic neoplasms. It's important to know about others as well because we have seen the others can happen over time in people who may have one type of histiocytosis. Diagnosis of ECD is very complex. The burden of proof lies on the clinician compared to the other histiocytosis or other cancer. The clinician has to be thinking about it. Otherwise, the diagnosis will be missed. And we need to really know the natural history. When we say natural history, it's not just what happens after the diagnosis as we know it. The natural history is how does it start, as people have done in myeloma and other cancers. And how can we get to that answer is by participating in research. So I highly encourage everybody to help us, help the community by participating in the registry and the follow-up study. With that, I will end. I hope it was clear. And I will take questions if I have any time. Thank you.